We are live.
Good evening. We are back with our walk-in patient series. Relieved with the news of the ceasefire, we begin our walk-in patient series with bacterial keratitis, how to diagnose, triage, and manage. Today, our chairperson is Dr. Radhika Tandon, along with Dr. Partha Biswas, who is the president of AIOS. Professor Tandon is the chief of RP Center for Ophthalmic Sciences, AIMS, New Delhi. The moderator and also the program director is Dr. Revati Rajaraman from Arvind Eye Hospital, Coimbatore. Our co-moderator is Dr. Radhika Natarajan from Shankar Nethralaya, Chennai. We have eminent panelists, Dr. Elmer Tu from University of Illinois, Chicago, USA, Dr. Seedsman from the Proctor Foundation, UCSF, San Francisco, Bhupesh Baga from LV Prasad Eye Institute, Hyderabad, Dr. Josephine Christie from Aravind Eye Hospital, Pondicherry, Professor Vanati from RP Center for Ophthalmic Sciences, New Delhi, and Tushar Agarwal, Professor from RP Center for Ophthalmic Sciences, New Delhi again. Our presenters are young and obviously bubbling with enthusiasm. They're Afreen Bari from RP Center, Charuta Shrotriya from LV Prasad Eye Institute, Hyderabad, Indrajit Kaur from RP Center again, Nishit Vivedi from Shankar Nethralaya, Chennai, and Namita Mohan from Arvind, Coimbatore. That's the extensive program that has been devised. I hand you over to Dr. Revati.
Good evening. I hope you people can hear my voice.
Yes, ma'am.
Yeah, thank you. I have to really shout. Um, Thank you, Dr. Honavar, for giving this opportunity, and also Dr. Radhika to um, agree to be the chairperson here, and all my panelists, the eminent panelists, including Dr. Elmer too. I think it must be early morning for them. They are so great to join us. And bacterial keratitis is a very important one because in India, somehow we got tuned to only fungal keratitis because it's very common for us. Always we think any ulcer it should be fungal until otherwise it's proven to be otherwise. So, but we have to keep in mind about bacterial keratitis because unless it is recognized immediately and intervened immediately, it can lead on to devastating problems. So we have young speakers now who are going to share their interesting cases and also the panelists who will be discussing these cases. And finally, Dr. Tandon will give us some overview of what all the take-home points finally. Thank you. And I'll call Afreen Bari to start her presentation. Thank you, Radhika Nadarajan, to join me as a co-moderator.
Good evening, ma'am. Are my slides visible?
Yeah, just put it on show.
Yes,
Slide
full
show.
screen. Yeah, yes,
Okay.
all of.
Perfect.
Good evening. I am Dr. Afreen Bari, and today I'll be presenting a case of contact lens keratitis. There are no financial disclosures. A 23-year-old male presented with pain, redness, and diminution of vision in the right eye since 5 days. It was insidious and progressive. He had history of contact lens use. He had been using extended wear type of contact lens. He was a student by occupation and had no known systemic illness. On examination, his right eye vision was hand movement close to face, PR was accurate, and left eye was normal 6 by 6 with glasses. On examination, we could appreciate that there was conjunctival congestion and there was a large infiltrate of around 5 into 5 square, around circular in shape, with an immune ring which is highlighted with arrow, and a hypopion of around 2 On slit examination, we could appreciate that in the center there was a significant area of stromal lysis or thinning. So immediately the patient was taken for corneal scraping. On staining, we could appreciate pus cells and KOH stain was negative. He also had his contact lens and the solution. They were also sent for bacterial and fungal culture along with the scraping material. So in this case, we were suspecting a very virulent organism since the history was short and the patient was started on eye drops, polymyxin and vancomycin 1 hourly along with cycloplegic atropine 3 times per day. On the next day, we could appreciate that the hypopion had decreased in size to around half. The immune ring had also decreased, and upon slit examination, we saw that the area which was the area of thinning that had also recovered quite a lot. That was not there as on the day 1. After 48 hours, the patient improved further. The infiltrate density had significantly reduced. The immune ring had totally cleared up, and hypopion was less than 0.5 mm. So then we decreased the 45 drops to 2 hourly polymyxin and vancomycin, and considering it to be a bacterial keratitis, we started prednisolone phosphate 6 times per day. On the next day, we saw that the hypopion had completely resolved and the infiltrate density reduced further, and there was no thinning. We also did anterior segment OCT to quantify the amount of thinning and monitor it, since we had put the patient on topical steroids. On day 7, the infiltrate density reduced further, and there was just this small 4 into 4 epithelial defect. By this time, we also got the culture report from microbiology. We got the positive report from the contact lens solution. It was Pseudomonas aeruginosa, and it was sensitive to polymyxin and imipenem. So we modified the treatment further. We decreased the drops to 4 hourly, and even we tapered the steroid to 4 times per day. At 2 weeks, the epithelial defect had decreased further. The infiltrates had nearly resolved. We could appreciate that on anterior segment OCT, there was just few areas of hypoechoic areas. Rest, they were almost healing. Now we modified the treatment further. We decreased the polymyxin drops to 4 hourly. We stopped vancomycin and tapered prednisolone phosphate. And we added lubricants, preservative-free sodium hyaluronate. Now this was 1 month follow-up. The patient's uncorrected visual acuity improved to 6 by 12 parts. There was formation of macular corneal scar, and there was the scar formation could also be appreciated on anterior segment OCT with a compact cornea of 480 microns. To summarize, this was the presentation and this was the final outcome. So in these cases, it is very important to have a high suspicion of virulent organisms, because these cases they present with the insidious history and with a very aggressive looking ulcers. We have to keep in mind Pseudomonas aeruginosa in these cases. When the bandage contact lens and solution is available, they should always be sent for culture, because in this case we got positivity from the bandage contact lens only. Timely initiation of the topical steroids is also essential, and monitoring corneal thickness along with it is also important, so that you taper the steroids and you can regulate the healing according to it. And timely adding lubricants is equally important to avoid any kind of epitheliotoxicity and any kind of neurotrophic or any PD, any persistent epithelial defects. Thank you.
Thank you, Dr. Flynn, for the wonderful case. Um, can I invite Dr. Agarwal? I think he is going to
Mm,
discuss about the case.
yes. So, thank you very much for inviting me to be here. Now, this case highlights I think it highlights two things for us. One is the kind of presentations we get at a tertiary care center and our approach, which is a little different. The kind of cases we get have normally visited quite a few places. You know, we normally don't get fresh ulcers. We get ulcers which have normally been treated with by multiple people and using all the conventional antibiotics at our disposal. So our default option generally is to go for the non-conventional or the non-regular antibiotics. For example, in this case, polymyxin V and vancomycin. The history and clinical features, especially contact lens induced keratitis with an immune ring, Pseudomonas was a very sort of a secure clinical diagnosis as well. There was a paper published in AGO about 10 years back, I think I quote that paper in a lot of my presentations and talks and classes that they had I think it was done from joint study from Arvind and some US group, and they had evaluated the role of clinical examination and correlated it with the actual microbiology. And they had found that it is very useful in cases of Pseudomonas keratitis, especially of all bacterial keratitis. It doesn't mean that we replace the microbiology. What it meant was that in about 80% of it had an 80% concurrence of the clinical findings versus the actual microbiology. So Pseudomonas, if the picture is clear in your mind, along with the clinical presentation of a contact lens induced keratitis, I think this approach works very well. And the timely addition of steroids, I think, also has led to a quick recovery or a marked improvement in this case. Once you have microbiological control, it may come in 48 hours, it may come in 3 or 4 days. Steroids greatly help the recovery process and improved outcomes.
Thank you, Dr. Agarwal. Um, Dr. Elmer, would you like to add some points here?
Thank you for including me. Can you hear me? Yes?
Yeah.
Yes, please. Yes, please.
Thank you. Thank you for including me in this program. I always enjoy them quite a bit. And I think Dr. Tushar's evaluation of the patient is absolutely correct. We see these patients quite often. I think one of the things that, even if you can't necessarily identify an organism, I think when you see this amount of inflammation, you can at least categorize it as a gram negative. Most gram positives in that short period of time, other than strep, are going to be more muted in their inflammation. And so it can help direct your therapy in terms of intensity. But of course, empiric therapy is always very important when they first come in as a fresh ulcer, as Dr. Tushar had mentioned earlier. And I wouldn't be dissuaded by the immune ring. I mean, I think often we get these patients in for, is this acanthamoeba or something of that nature? I mean, there have been reports about 20 or 30 years ago, my partner Joel Sugar had reported a patient with a Pseudomonas ulcer who actually had a radial keratoneuritis. And so, it should always be treated as bacterial because that's the thing, as Dr. Ravati mentioned earlier, is going to affect your vision the soonest. So I think the management was excellent and it looks like the outcome has been quite good.
And Dr. Christie, this case, you can see there is a scar left behind. And at this stage, how do you think like we can go ahead with for the visual rehabilitation? Anything we need to do? And what about the advice to the patient about continuing the contact lens?
Yes, ma'am. So, especially for contact lens wearers who had a keratitis, we strongly counsel them about the need for hygiene, and extended wears are they're asked to avoid it. And also we ask them to use daily wears if at all possible. And then about the corneal scar that this patient had, luckily the thinning stabilized very well. And the thickness also was decent enough. I think after a month or so, even for the astigmatism with a rigid gas permeable contact lens, the patient will be able to get a very good visual outcome. And I also wanted to add a few more points, ma'am. So for this patient particularly, the corneal scraping for Grams and KBOH, I think it revealed pus cells. So especially when we deal with these kind of gram-negative bacterial post-contact lens, where we have a higher suspicion of Pseudomonas, there's a lot of pus cells. So we should make sure to avoid all those melting tissue and try to take a better corneal scraping so that we will be able to immediately identify there is a gram-negative rod, and we completely avoid using vancomycin, which is completely a gram-positive targeted antibacterial. And I would have definitely preferred a fluoroquinolone in this kind of a patient because it has a good coverage of both gram-positive as well as a gram-negative. And we call them for closer reviews, or we admit the patient also. And especially for contact lens wearers who had developed keratitis, I find that fluoroquinolones do very well. I mean, only for patients who have compromised ocular surface already, and then they are put on extended wear BCLs, and then they develop a Pseudomonas keratitis, there is a high suspicion for multi-drug resistant Pseudomonas. There, I wouldn't start a fluoroquinolone to start with. I would have preferred a tobramycin. So for naive corneas, which has developed ulcers, I would have preferred a broad spectrum antibiotic. So
Thank you.
I think it also depends on the area. The antimicrobial approach also has to be tailored according to the patterns which we see in a particular area. As the report in this case highlighted that it was sensitive only to, it ended up being sensitive only to polymyxin B and one other antibiotic, and not to any of the fluoroquinolone, including moxi or gatifloxacin. And that's the pattern which we normally see at RP center, that most of the gram-negative bacteria which come to us later on, they seem to be resistant to these fourth generation fluoroquinolones plus tobramycin as well. So
okay.
that's why especially in the last, I think I think somewhere around COVID time, probably around last 4-5 years, we have shifted to polymyxin B wherever we are suspecting gram negative. The other thing which I already highlighted when I was discussed the case was that most of these cases which we get in RPC have already been on all these drugs. So for at least a couple of weeks or more. So we know that those drugs haven't, the patient has already worsened on those drugs. So that's another sort of reason why we prefer this kind of antimicrobial therapy. And last but not the least, once we do see an evidence of thinning in these ulcers, then also our approach is to avoid fourth generation fluoroquinolones, especially gatifloxacin, as it is known to promote collagenase activity and thereby increasing the chances of the risk of corneal perforation as well. So that's another this is our sort of tailored approach in RP center. Of course, it may vary in other parts of the country, but this is sort of what we have gathered over the years with our
Yes.
whatever observations.
Agree, sir. And also,
That,
even after noting that it was a gram-negative organism, I think vancomycin was given 4th hourly and then tapered. Is there a specific?
yes. Yeah. So at that, as Dr. Afreen highlighted, the culture reports came a little later, and they were not made available at that time. First reason, and secondly, the culture report came from the contact lens itself, not from the patient. So that I think was the reason that it was little tapered off rather than being withdrawn immediately.
Thank you, sir.
Dr. Agarwal, would you like to add doxycycline tablet here? Because as shown market thinning.
Yes. So we do use doxycycline to manage when there is thinning, but normally it could have been used. It's perfectly right, but normally my approach is to add it when I document progressive thinning. If the thinning is improving on its own in a couple of days or it stabilizes, then we don't normally go to doxycycline. But yes, in any case of progressive corneal thinning with corneal ulceration, we do like to add doxycycline oral.
Good, thank you. Hi, Dr.
May I
Jeremy.
make a comment?
Yeah, yes, Dr. Elmer. Yeah, carry on.
Oh, I just wanted to make two comments. One, to reinforce what Dr. Tushar mentioned, is that fluoroquinolones can promote melting. And there was a study from Australia many years ago when they first introduced fluoroquinolones that showed that had a much higher perforation rate after the introduction of fluoroquinolones to the continent. So it's something to keep in mind. In this particular case, the second thing that I wanted to point out is, that there was concern over thinning in the center, but I'm not sure that that was true thinning, because in this particular case, afterwards, stroma doesn't reconstitute after, even after inflammation. So I think this was a relative area of thinning, and it was an area that was devoid of inflammation, meaning the inflammation didn't reach that area. So you had relative edema around it and a small clear zone in the center. In an acute situation like this, normally that's not thinning. That's just, the surrounding cornea looking worse. In more chronic inflammation, then of course you can have thinning in that area. So my guess is in this patient, I probably wouldn't have added the doxycycline just because I wouldn't have thought that there was actual true clinical thinning. So
Yeah, and any kind of, as I mentioned, any kind of progression, little bit of progression, that sort of bolsters the finding that the thinning is there and it's progressing. So that's another sort of our clinical tip, that when we see a little bit of worsening, then we add doxycycline. Not per se, not like at the beginning of the case. This case, of course, improved very fast, so we didn't see any need.
Thank you. Very interesting case, Doctor. Um, Dr. Radhika, I think we will move on to the next case, I think from your institute. SN?
Sure, Epti ma'am. So that was a very good discussion on Pseudomonas keratitis after contact lens use. So we follow with the same organism but under different clinical situations. So I invite the bright and young enthusiastic Nishi Dwivedi, my cornea fellow, to present the case that we co-managed recently. Nishi, over to you.
Thank you so much, ma'am.
Just a moment, Dr. Jeremy. Hi. I saw you joined. Yeah, hi. Thank you.
Hello, Dr. Jeremy.
Nice to see you all.
Dr. Nishi, please carry
on. Are my slides visible, ma'am?
Yeah, your slide is visible, but put on slideshow and you're audible as well.
Is that okay?
Yes, good to go.
A very warm good evening to everyone. Today I am going to present an interesting case of post-CXL multi-drug resistant Pseudomonas keratitis, presented by myself, Dr. Nishi Dwivedi, Cornea Fellow, under the moderation of Dr. Radhika Natarajan Ma'am, Director, Department of Cornea and Refractive Surgery, Shankar Netralaya, Chennai.
Sorry to interrupt, doctor. Can you just hide the floating bar on the screen?
Sure.
Thank you. So nice.
Is that okay? Yeah.
Perfect.
Thanks. So this 30-year-old lactating mother with a recent history of bilateral CXL done elsewhere 2 weeks before presented to a center with a complaint of pain, redness, watering in right eye since 1 week. Also with the complaint of diminution of vision, and there is also an alleged history of trauma in the right eye from child's hands 5 days ago. The vision noted was hand movement with PR accurate, and the left eye was within normal limits with the vision of 6.6. There was no systemic illness as such. On the slit lamp examination, as we can see clearly in the diffuse slit lamp photo, there was central corneal infiltrate approx 4 into 5 mm with a hypopion of 3 mm. In the cobalt blue filter, we can see that the overlying 3 into 3 mm epithelial defect as well with few satellite lesions. So we did corneal scraping, and on the direct microscopy, we can see the encircled gram-negative bacilli morphologically resembling to Pseudomonas. We started on fortified amikacin 12 times a day with moxifloxacin 1 hourly along with the supportive medications. We also did ultrasound and it was within normal limits. On the very next day, we saw that the lid edema has significantly increased along with the infiltrate enlarging to 5 into 5 mm. As we can see in the slit lamp diagram, there was thinning with desmetocele, hypopion with 2.2 mm as well. So we did cyanoacrylate glue with the BCL. And on the meanwhile, on the microbiology report, we can see in the cultures the translucent non-hemolytic colonies, which was identified as Pseudomonas aeruginosa. And we switched, which was actually in the antibiogram, we can see it was resistant to almost all the known antibiotics. And we didn't do gentamicin sensitivity at that time, and we switched the patient to gentamicin eye drops 1 hourly, and we planned for right eye early reglue BCL bar Tennant's patchcraft bar therapeutic penetrating keratoplasty based on intraoperative findings. Intraoperatively, as we have after we removed glue BCL, there was a frank central 2 mm perforation with, we can clearly see in the slit lamp photos, the exudates extending up to the anterior lens capsule. The decision of therapeutic penetrating keratoplasty was made, and the corneal button along with the AC exudates was signed for microbiology. In the post-operative course, on the day 1, there was clear graft with no recurrence. So we started on the patient based on the previous sensitivity report only with the eye drop imipenem and the gentamicin along with the supportive medications. On the day 3, the graft was clear with no recurrence, and also we got pseudomonas on the from the corneal button as so a 7 with the cherry on top, we see that there was MRSA staph isolated from DCR as well. So we started based on the antibiogram of DCR donor corneal rim, the eye drop getifloxacin, and as there was the clear graft with no recurrence, we started on patient with eye drop lutipred as well 6 times a day on the tapering doses. This is the longest follow-up of 1 month with a clear graft and no recurrence. So the points of discussion is multi-drug resistant pseudomonas, post-CXL infection, rapid progression and the risk of corneal melt, implication of lactation. Reversely, CXL is also used as a treatment for infective keratitis as it can have direct antimicrobial effects and improve the corneal resistance to enzymatic degradation as well. Early TPK, often necessarily in MDR infections. Post-op monitoring, yes, is the vigilance key for recurrence and graft survival. And yes, never to forget, monitor your DCR rim as well. These are my references. This is the sequential photos. The patient with presented day 1 to us with the corneal melt, acute corneal melt with thinning and desmetocele with the clear graft with no recurrence and at the longest follow-up. Thank you so much.
Thank you, Nishi, for that clear presentation. You can close your presentation window for the discussion. So the highlights of this case were that the patient developed an infection in an eye that was post-collagen cross-linking treatment. We can't really call it a post-CXL infection because it happened after injury with a child's hand much later. Nonetheless, the infection happened in a cross-linked cornea. So the way we understood it was that due to the cross-linking, the drugs were penetrating poorly. And because of the loss of keratocytes, the repair was not happening properly. And in our minds, that was the reason that the melt progressed almost overnight. And the second concern was it was virtually either fully resistant or partially resistant to almost all the antibiotics. We had only shown one representation, but then when we retested also, almost all antibiotics came out as the organism was resistant to all antibiotics. The third confounding factor was that she was a lactating mother, and we did not have, even based on literature reference, whether some of these antibiotics could actually be used in a lactating mother, even with punctal occlusion. So, to be on the safer side, she was asked to bottle feed her baby for some time. The last point may not be that relevant, but the donor corneal rim did grow something. We know that quite often it does grow something, and unless it's fungus or some other anaerobic organism, we really don't attach that much importance to that. But that was also a factor. So based on all these 4 counts, in a post-CXL MDR infection in a lactating mother, is there anything else that could have been tried? And before asking the question to the panel, I just want to also point out that like Nishi showed very quickly, intraoperatively, we saw that the infection had almost reached the anterior lens capsule. So that kind of, dramatically showed to us the effect the cross-linking had on playing a permissive role to the infection as such. So I ask for the panel to discuss on this. Dr. Tu, Dr. Salesman, Dr. Agarwal, Dr. Christie, Revati ma'am, yourself. Anybody can start the discussion.
I think it's a very interesting line of thinking that the cross-linking actually impeded the healing or impeded the healing response to the keratitis. And it's definitely worth sort of looking into even in the future, I think the cases, because cross-linking itself has been used to treat the infection. And in general, I would have imagined that a cross-linked cornea sort of would be
Fortified.
more immune sort of to the effect of the lysis by the pseudomonas or the toxins produced by pseudomonas. But I think that opens up a really new way of looking at these patients for me.
Actually, that was the thought process here as well, because on one hand, we think it's a strengthened cornea, which will kind
Yes,
of,
yes,
even we
yes,
have a paper from SN
yes,
where we had
yes,
demonstrated that a cross-linked donor cornea also actually retards a reinfection. But on the
yes,
other hand, this is just a hypothetical thinking that, we thought that the drug penetration is definitely altered in these cross-linked corneas, number one. And
yes.
though the cross-linked effect may be there, the keratocytes themselves are fewer in number, that the balance can sometimes tilt the other way, but that's just a hypothesis. I would be happy to know the others' viewpoint on this as well.
Yes, Radhika. In cross-linked corneas, if you get infection, sometimes, of course, they go out of hand and we have to do keratoplasty. But what I observed, when you do keratoplasty, even therapeutic in these cases, many of the grafts survive for a longer time without reinfection. The reinfection rate in these corneas, even if the infection is very large, you do a very large graft, it's very, very less. Even in acanthamoeba, I have seen few cases of acanthamoeba after cross-linking and needed to go for a large TPKs. But generally, reinfection is almost like, almost nil.
That's a very nice observation, Revati ma'am. Dr. Tu and Dr. Jeremy, I would like to ask you that in a case of multi-drug resistant infection like this, there are two ends of the spectrum. One end is to try medications like aztreonam, piperacillin, which we don't, routinely use as antibiotics. So we've used in the past in anecdotal cases, we just reformulate the injectable forms based on literature recommendation and we use it. So have you ever tried those antibiotics? At the other end of the spectrum, we have the good old gentamicin, and I believe sometimes it does work simply for the reason that gentamicin has not been around for a very long time, and therefore, the sensitivity or the response of the organism is better. So, what do you think of utilizing medications at both ends of the spectrum? Very advanced or very new ones versus the ones which have been forgotten in history?
Well, you have a beautiful case of a very severe disease that was managed beautifully. And then the question that we always struggle with is, should this be managed medically or surgically?
Exactly.
In multi-drug resistance, it's tricky because you're really lending a lot of your therapeutic decisions on the MICs of that particular drug, of what we think to be sensitive. And then in our nuanced field of corneal infections, we give an asterisk and say that we have this ability to overcome some resistance because we can pour the drop directly onto the eye. So the management is, I think we would all agree, medical until it looks like it can't be anymore. And so I think you had a very rapidly progressive disease and it looked to turn surgical quickly, and that seemed reasonable. If you knew it to be multi-drug resistant earlier and it hadn't progressed, I think it's reasonable to try. A lot of multi-drug resistant in the United States are sensitive still to meropenem, which is tricky to have compounded, but possible to have compounded. The other thing I just wanted to mention, just as a general concept, is you had originally a Pseudomonas that was rapidly progressive. And there are many reasons for a bacterial infection to be rapidly progressive. And one of them, of course, yours was multi-drug resistant, but one of them is that there's a secondary infection. And the other is that it's an infection on a neurotrophic cornea. And so I wasn't sure how recently postoperative they were, but any cross-linking is relatively neurotrophic right after the procedure. And in the United States, at least in California, we tend to always check for the herpes viruses. And so it seems now in your case, this was multi-drug resistant, but in the other case of a drug sensitive Pseudomonas, the combination of HSV and Pseudomonas, that often progresses to perforation really quickly. So when you're progressing very quickly, you always are thinking about neurotrophic, multi-drug resistant, an enormous load, or secondary infection. So some of my thoughts.
Point very well taken, Dr. Jeremy. Ours was a few months after the cross-linking, but then these corneas are denervated even with cross-linking. They're denervated in the very beginning, so HSV recurrence is a possibility. But how do you prove or disprove it? Do you take a PCR for HSV? If so, do you do a quantitative PCR to see that the virus is actually replicating as a co-infection to the bacterial organism? How do you prove or disprove it?
We do PCR that's not quantitative, and if it's positive, we treat it anyway because the treatment is, it's possible to have shedding virus, but it's more likely to have either primary virus or reactivated virus in that setting.
Right. Any other pearls from yourself or anybody else? This patient was a lactating mother. Do you have any wisdom on how we can deal with that, except for forcing her to bottle feed? Because we were trying various medications and we could not really get relevant history authentically on each of them, to tell her confidently that you can breastfeed. So, she was resorting to formula for some time. So is there any other thought on this? Christy?
No, even when the other concern is that when the patient is taken up for a therapeutic keratoplasty, we also need to administer a lot of systemic medications in relation to the anesthesia requirements, post-operative pain management, and all those things. So, in addition to the antimicrobials, the other drugs which need to be given when the patient is undergoing a therapeutic keratoplasty and the post-op management, those also come into play. So in these cases, the best bet is what you have done, that taking the lactation off the table.
Child off the mother for some
Yes.
time.
Yes.
So
Yes.
I think Dr. Christie made a very important point in the last case that applies universally and here as well, of using number one, the area because this was a smallish kind of ulcer and it progressed more vertically down rather than horizontally towards the limbus, and that was the need to do the TPK. So given the limited amount of ulcer that we have to scrape, it has to be always at the leading edge of the ulcer. Because where the scarring has started, if we do the scraping, we would get just fibrous bits. And where the necrosis is happening, if we scrape, we just get pus cells. And I think she made a very important point about scraping the leading edge of the ulcer. And the other point which Dr. Tu mentioned, we did not have time in this patient to do it because she almost melted immediately. But the ASOCT also helps. Or recent times, we've taken doing OCT for these patients so that we can distinguish relative edema from actual thinning. Is that area thin and the other area normal, or is that area normal and the surrounding area thicker because of edema? The ASOCT, sometimes points out reasonably well. So, we've taken to doing ASOCT to address that particular concern. Any other inputs, Dr. Radhika, Dr. Tu, Revati ma'am, yourself? I am not sure I'm not missing out anybody else on the panel. If so, you can please speak.
Dr. Bhupesh, Dr. Baga, welcome. I think he said he'll join later. He has joined now.
Bhupesh is here.
Yeah.
Hi.
Hi.
Hello, everyone.
Do you like to add anything, doctor?
Bhupesh, did you have a chance to hear the case being presented?
Yeah, no, not the case, but I think when the case was ending.
So basically, the crux of the case is a lactating mother post-cross-linking. She didn't develop a post-cross-linking infection. Much later, a couple of months later, because of injury, she developed multi-drug resistant Pseudomonas infection. And it almost perforated immediately. So how to counter multi-drug resistance and the difficulties in a post-CXL patient and, a lactating mother, how to give drugs. So these were the queries in this patient. Luckily, she did beautifully with therapeutic PK, but any more inputs would be appreciated.
Yeah, so experience with the post-collagen cross-linking multi-drug resistant E. coli and some Pseudomonas keratitis bilateral. So these cases are actually very tricky, and but the learning lesson from these cases, whichever I have managed and I have seen management, better to avoid doing aggressive in terms of doing therapeutic keratoplasty. We need to tend not to do therapeutic urgently, better to attempt tectonic other way like multilayer AMG or applying the glue BCL and torsoraphy along with the use of colistin or imipenem. These drugs are actually working very well, and because they do respond nicely within the span of 2 to 3 days with the TABCL along with the torsoraphy and with intensive colistin or imipenem. So I have 3 or 4 pair of eyes, means around 3 patients where the responded nicely, and later on when the everything set, then after 6 months or down the line 8 months, did optical keratoplasty of these patients, and they are doing pretty well without development of any major complication.
So actually in this patient, Nishi, if you can very quickly put up the intraoperative photo, the decision was also to do a more conservative surgery in the form of glue BCL or even Tenon's patch graft. I've done them for a few infective perforations with good result. But what surprised us on table was that the perforation was not the surprise, but the infiltrate actually touched the anterior lens capsule and it was contiguous from the cornea. So that is what prompted us to, if you can see in this intraoperative picture, from the top of the cornea to the back of the cornea up to the anterior lens capsule, the infiltrate was, contiguous. So we decided to go ahead with the therapeutic PK. And because it was bacterial and because it was for the depth of infiltration and not the width of infiltration that we did the TPK, we started steroid almost immediately. And we were lucky to get a clear graft. But I agree with you. Conservative treatment of the threatened perforation will always bode well for this patient because like Revati ma'am said, once it is contained cross-linking cornea, it usually doesn't, recur that very much. I think we've had a very good discussion on this case, Revati ma'am. So I hand it back to you. Thank you, Nishi, for the wonderful presentation and thanks to the panelists for the discussion. Ma'am, I think it's time to take over the next case.
The next case, we can go to LVP presentation. And since Dr. Baga is already here, we can go on to Charita's presentation. Dr. Charita, are you here?
Yes, ma'am, I am here. I am unable to share my presentation, however.
I think somebody have to stop sharing because I'm seeing two screens. Now it's fine.
If my screen is visible.
Yeah, we can see.
Good evening to the esteemed consultants and my dear colleagues. My name is Charuta and I will be presenting on two cases of post-PRK keratitis, which involve patients of similar backgrounds, clinical profiles and causative organisms, but with markedly different outcomes. So our first patient was a 26-year-old female who came to us with complaints of watering, pain and discharge in the right eye since one day. She had undergone PRK in both her eyes elsewhere 2 days ago. She consulted elsewhere, was diagnosed as bacterial keratitis and was prescribed a treatment regimen of topical ciprofloxacin, homatropin, fortified topical piperacillin, tazobactam, oral doxycycline and NSAIDs. She had central fungal infiltrate 7 to 8. The left eye had a visual acuity of 20 parts. The lens and epithelial distance measuring about 0.5 into 5 mm with an underlying anterior stroma infiltrate. A scraping initially gram-negative villi and started treatment of ciprofloxacin.
Slides visible?
No. Audio also gone.
Yeah, Charita, your slides and audio is not there. Can you reshare?
Sorry, sir, the connection is unstable. Sorry, sir.
After the first slide, I don't think so. The slide moved.
Is the screen visible again?
Yeah.
Yes, full screen, please. Yes.
May I know where the connection went off so I could start?
The first slide where you showed the first clinical picture. No, before that. Yeah. That was there. Next picture. You were describing it you have to describe it again.
Sorry. The right eye had a vision of PLPR inaccurate. She had severe congestion and discharge. And here we see a diffuse slit lamp image showing a central mid to deep stromal infiltrate measuring about 7.5 to 8 mm with a 6 mm hypopion. The left eye, meanwhile, had a visual acuity of 20 by 50 parts. The BCL was still in situ, and she had an epithelial defect measuring about 0.5 by 0.5 mm with an underlying anterior stromal infiltrate. A scraping revealed gram-negative bacilli, and she was started on a treatment regimen of ciprofloxacin 0.3% hourly, atropine thrice daily, and doxycycline 100 mg twice daily. Now, on day 2, the vision was PLPR inaccurate and there was no response on treatment. The infiltrate was still status quo. Here we got the sensitivity report, which revealed Pseudomonas aeruginosa, which was pan-drug resistant and with intermediate sensitivity to colistin. So we started her, we shifted the treatment to colistin, topical colistin 0.19% hourly. The BCL, meanwhile, from the left eye had also grown colistin, which was pan-drug resistant. Pseudomonas, which was pan-drug resistant with intermediate sensitivity to colistin. Here we see a serial improvement after starting topical colistin. The infiltrate started to respond, and by day 5, the patient regained a vision of hand movement. By day 7, the vision further, the infiltrate further reduced, and as we can see here, the infiltrate was largely deep. Here we decided to start topical steroids, and prednisolone acetate 4 times daily was added to the treatment regimen. After this, significant improvement was noted serially, with the vision improving to counting fingers close to face on day 10 and significant reduction in the infiltrate, which continued at 3 weeks with the vision improving to counting fingers at 3 meters. And at 1 month, where the infiltrate had nearly resolved with scarring and the vision had improved to 20 by 800. The colistin was tapered to 6 times a day, and the topical steroids were tapered down to weekly. At her 2 months follow-up, the infiltrate had completely resolved with diffuse macular grade scarring and a visual acuity of 20 by 200. And at her latest follow-up, she has a diffuse scar with a best corrected visual acuity of 20 by 30 parts. The left eye responded very well to treatment. She was started on topical colistin 4 times a day, and within a few days, she regained a vision of 20 by 25 with complete resolution of the infiltrate. Coming to our second patient, who is also a student, 25-year-old female, came with complaints of watering, pain, and discharge since 1 day, having undergone PRK elsewhere 3 days ago. She was also diagnosed as bacterial keratitis and prescribed the same topical medication as the previous patient. She presented to us with the vision of PLPR accurate in the left eye, mid to deep stromal infiltrate measuring 6 to 6.5 mm and a 2 mm hypopion, while the right eye had a paracentral mid to deep stromal infiltrate and a streak hypopion. Similar to the previous patient, the scraping reported Pseudomonas aeruginosa, which was pan-drug resistant and intermediate sensitivity to colistin. And we started her on a treatment of colistin hourly, atropine thrice daily, and doxycycline twice daily. The right eye responded very well to medication. By day 4, the vision had improved to 20 by 100. And within 1 month, the infiltrate had completely resolved with scarring and the best corrected visual acuity of 20 by 20. The left eye, however, could not be salvaged with topical medication alone. There was rapid worsening and she had to undergo therapeutic penetrating keratoplasty on day 5. We started her on a post-operative treatment regimen of colistin hourly and prednisolone twice, 2 hourly with a 2 weekly taper. And she responded very well, and this is her follow-up visit at 4 months with a best corrected visual acuity of 20 by 20 with early cataractus change. Some key takeaway points from these 2 cases would be that infectious keratitis after PRK is rare, but can be rapidly progressive and visually devastating if not recognized promptly. While Staphylococcus aureus is the most common PRK pathogen, this case shows us the importance of considering atypical organisms like pan-drug resistant Pseudomonas aeruginosa. Judicious and timely integration of steroids in the treatment can rapidly and significantly improve outcomes. The source of the infection should be isolated with a microbiological analysis of the eye drops, the BCL, OR instruments, and saline. Bilateral surgery and rapid onset of microbial keratitis should raise concerns for possible intraoperative contamination and emphasizing the need for vigorous institutional protocols. And the successful outcome demonstrates that with a good microbiological backup and knowledge of atypical organisms, even in severe infections, we can restore functional vision with conservative treatment. Thank you.
Call Dr. Baga to discuss this case.
Yeah, thank you, Charita, for the presentation. So these two cases are actually having some similarity that they both were having status post PRK, and one eye is much more advanced than the other eye. And the common thing is also that their organisms are multi-drug or pan-drug resistant, basically the susceptibility to only colistin, intermediate colistin susceptibility. And both were teenage, or you can say some young females, and they both presented in a span of 1 to 2 days after surgery. And the pattern of presentation were also same, that severe infiltration along with thinning and with very fast progression. But fortunately, we could start them the span of second day only, the colistin, or with the assumption that we are dealing with the XDR or MDR Pseudomonas, because we have seen these cases being managed with the primary drug, with the primary physician, and they come with the perforation previously and land up into bilateral urgent therapeutic keratoplasty with very poor outcome. So with the experience of learning from previous cases, we know that in the early stage only, if we hit them hard with the drugs, which are primarily can be for use for MDR or XDR Pseudomonas. So these cases, we started even from the beginning itself, colistin, and with the application of TABCL in the one case, and the other case with the only medical treatment, we could achieve very good visual acuity. So the learning is Pseudomonas, although looks very big, sometimes 8 to 9 millimeter, but if you hit hard and hit timely, it responds very nicely. As you have seen that patient, the first vision is improved to 20 by 30 parts. Even the infiltrate was too big, and the necrosis was, thinning was almost 40 to 50% at the beginning itself. Second patient, we could not save the one eye from the therapeutic PK, and within 1 day, the iris started showing up. So we took the patient urgently for therapeutic PK. And at that time, even the therapeutic PK graft was large. The patient has completed now almost 10 to 11 months with a clear graft and 20 by 20 vision, but with the use of intensive steroids and keeping the finger crossed that till now the pressure and disc and lens and everything is clear, and disc is also normal. So basically, if you have little bit advanced then Pseudomonas and understanding that it can be a XDR or MDR, treating it timely and treating little bit more aggressively, we can have good vision. But the sad thing is we could not find the source from where they develop this type of XDR Pseudomonas, in spite of trying to trace the organism and trying to trace the surgeon and the drops and the way it was done, we could not get it. But fortunately, none of them from their day of the cases had this type of cases on the same series, like same day or same 1 week. They could not have the Pseudomonas keratitis. So it's maybe a contaminant from the sterilization, but we could not actually pinpoint them from where this organism is coming.
Very interesting. Dr. Tu, would you like to add something?
Sure. I have a First of all, we haven't managed that many cases of MDR. The one we did successfully manage was medical. It was with colistin, and we actually used PHMB as well. And the patient did respond slowly. They had severe ocular surface disease, so it took a while for the epithelium to heal. But I think the two cases that were presented here and then the previous case does point out the issues with corneal surgery, and especially these sort of pan-corneal treatments of corneal collagen cross-linking and PRK, which both denervate the cornea, which makes it more susceptible. But you can see in the CXL patients, the pattern of inflammation was quite different. I think that the cross-linked cornea actually prevents inflammatory elements from getting to the actual infection. It makes it look smaller than it actually is, where you would normally see a much more expansive area involved. So that can throw you off clinically, first of all, but it can also make treatment more difficult because all the Langerhans cells have been eradicated as well in the zone of cross-linking. And then the epithelial defect was also going to heal much more slowly in these patients because of the denervation. So I think these patients are unusually susceptible to infection. And so you have to have a very high index of suspicion when you see these patients come in with any type of inflammation. I know that in some of my cross-linking patients, I've seen epithelial infections, bacterial infections on day one, where there's no stromal signs at all. And so when you do see these patients early, it's very important to pay attention to make sure that anything unusual isn't really an infection that you're not seeing a normal clinical response for.
Dr. Radhika Tandon, would you like to add something? Or Dr. Agarwal?
Yes, again, as Dr. Tu said, very severe cases of keratitis. And I think it also sort of gives me a little hope that a little positivity that we are tailoring our antibiotics, especially the tertiary care centers have to keep this possibility of MDR and XDR in mind. It may not be applicable to everyone who's hearing this, but as tertiary care centers, we do have to keep this in mind that we will get MDRs, especially in India. And again, a localized approach. By localized, I mean the area, the localized to that area. Because, for example, we hardly ever use this antibiotic in North India, and so that I think gives this credence to this theory that the antibiotic approach has to be tailored, and especially in tertiary care centers, where people normally, even in this case, was on I think 4 or 5 antibiotics previously prior to presentation. And as Dr. Bagga rightly said, that you have to hit them hard at the outset itself with the sort of your best shot at it. And with their experience, as he said, that this antibiotic works best in their hands.
So on the
Sorry, I just missed one point. Any sort of any experience with injecting the antibiotic in the anterior chamber if you find that the response is less, or intracorneal injections, just to increase the levels of antibiotics at the site of infection? Dr. Bagga?
Yeah. So antibiotics, I think should be preferred not to inject because these corneas are already thinned out and we're not aware of the toxicity of intracorneal toxicity, how they are. And the penetration is quite good of these antibiotics. So except antifungals, I
No,
don't.
just short of, I meant just when you see that eventually maybe in a day the patient is going to need at that point, like we know that okay, we are going to wait for another 24 hours and then we will go in for a therapeutic keratoplasty at that stage as a last sort of stop before taking up the patient for therapeutic keratoplasty.
I think to me, use of intracameral or intrastromal of use of antibiotics is not a great idea because the pharmacokinetics says that it stays only for a few minutes and it's not going to work there. And also, if you're putting intrastromal, you're not sure about the toxicity of antibiotics, and the penetration is quite good in the inflamed eye or inflamed cornea. So topical use is good. If you want to give some antibiotic as a preventive measure to avoid the spread of infection in the posterior segment, intravitreal dose safely can be given.
I want to ask a question that in between we had the availability of 1.5% escalated concentration levofloxacin. It kind of came with a bang. Right now, availability is also questionable. And when it was there also, when we used it, it did not give the promised response to these significant gram-negative infections. Does anybody in the panel have a different opinion or a good word to say about it? Or is it the same experience as ours?
Same experience, yeah.
Ma'am?
Yeah, same experience. What about Dr.
The only thing I was thinking about, these are terrible cases, of course, is sort of where getting to the source, and I appreciated the search about where to seeing if it was a source from the hospital or the surgeon. But Pseudomonas, these terrible Pseudomonas, where would it come from? The water, the soil, the hospital. And so it just also, in the first case of the extended wear contact lens, and in any procedure where we put on a bandage therapeutic lens, it really just reminds everyone, especially the residents learning, the importance that we have to really emphasize. We cannot open the eyes in the shower. We cannot use the tap water to flash our faces. And that I think most people do. And we, especially with contact lens, where the strict avoidance of water, especially in an immediate post-op, is critical.
I would make one last point along with what Dr. Jeremy just mentioned, but there have been studies on Pseudomonas that show that there are two forms. There's a cytotoxic form and a non-cytotoxic form, and sometimes the underlying Pseudomonas is going to act differently based on which strain it is. I mean, strains. It's not just one, but some of them are very aggressive, and so not all Pseudomonas is structured the same. I mean, some of them we pat ourselves on the back. Oh, this was Pseudomonas, but they're doing just great. Other ones, no matter what you do, even if it's not multi-drug resistant, they penetrate and destroy the anterior chamber. So sometimes it's the actual strain of the organism and not just the resistance. I mean, there are forms that create a tremendous amount of inflammation independent of what your treatment is, even if you give them steroids.
And along that way, they form biofilms very easily. So even if they're sensitive, it's hard to penetrate to get to them.
Thank you.
At the cost of repeating myself, I have started enlisting gentamicin in my list of sensitivity now because I have seen that because it's not been used very much in the recent past, many times the sensitivity is, shows up as a surprise, and then the patients who respond to gentamicin do so very quickly. So I'm not saying it's a panacea for every Pseudomonas, but then I'm enlisting it again in my list of sensitivity.
Yeah, I think gentamicin susceptibility is quite good. We also seen at present data from this last year, it is quite good for all Pseudomonas, but non-availability in India, particularly this side, I don't know about the north, maybe Dr. Tushar.
No, it is definite issue. Non-availability is a definite issue. We don't
here
have.
We are not getting gentamicin, but tobramycin is also having good susceptibility in that 1 year data. So gentamicin and tobramycin, I mean, is like quite good as it can be used as a monotherapy for gram-negative if you are suspecting gram-negative.
Yeah, these older antibiotics are coming to the rescue now. Yes. And so I think they need to be looked at, and we are always looking at the older antibiotics in a newer sort of light now.
But unfortunately, gentamicin is a very, very cheap medication. So the profit margin being very low, pharma companies are not very keen to actually make or market the drug.
I think in the US, Dr. Elmer or Dr. Jeremy, that the third generation or fourth generation cephalosporin, which was the use, I forgot the exact name, which was used when the XDR Pseudomonas cases came there, some fourth generation cephalosporin was used. some say for door call or something. They have used it and they recommended that this is the probably the best use. Michael Jiggins group has done it. The study.
Yeah, I know what you're talking about. We didn't have access to it at the time. I can't remember.
Because it's published in JAMA. I forgot the name actually. Fourth generation cephalosporin they have used for XDR. Okay.
Shall we move on to the next case?
Yes.
Yes, please.
Yeah, so I think with the discussion, that can go on and on the subject, we also have to give due diligence and consideration to the more interesting cases that have to follow. So I'm going to welcome Dr. Indrajit Kaur from RP Center to give us an account of what they have treated recently. Dr. Indrajit, are you there? Can you get your slides up?
Yes, ma'am.
Sure.
Indrajit, share screen, please.
Yes, sir.
Screen show,
Is
full
my
screen.
screen visible?
Your screen is visible. Please make it full screen. Screen show.
Now
Dr.
it's visible?
Yeah, it's visible. Can you just make it full screen? PowerPoint show board.
Yes, start the slideshow, please.
Just
Dr.
one second.
Indrajit, yeah.
Now it's visible?
It's loading actually.
It's loading. It's loading.
Any chance you could download this and then present?
It's visible or not? Actually,
No.
Actually, no. You are directly doing from the docs, right?
yes.
Can you download it and then present? Let's say another 1 minute or so.
Yeah, I'll try.
Just download it and then present, please. I think there is a bandwidth error also. You can just download and then present, please.
So as Dr. Indrajit is trying to figure out her presentation, I have another general question for the panel. We know that in virgin infections, there is very less role for systemic antibiotic, especially in bacterial keratitis. So in a case where the infection happens, say after the breakdown of the blood aqueous barrier, like post-operative or post-injury, then there may be a small role. But otherwise, there is no significant role for oral antibiotic. But with the advent of using ASOCT, like in our case, where we see an extension of the infection into the anterior chamber, just like antifungal, is there in specific domains any role for systemic antibiotic in bacterial keratitis? When we see the extension of the infection into the anterior chamber, where we know that reach of the drug can be there systemically also. Dr. Christie? You stop a short, Indrajit, whenever you get the slides up.
Okay, it's not visible here.
Please screen share on kariye.
Ma'am, I routinely give systemic antibiotics whenever I see that it is into the anterior chamber or intravitreal extension is there. So I usually do that because like as our normal protocol for fungal infections, also we start systemic antifungals. So that is how I
So,
follow.
a fungal infection, I would believe that the fungus penetrates into the anterior chamber the moment it reaches the posterior stroma. But we know that in bacterial, the hyperbion is usually reactionary. So with the ASOCT demonstrating, like in our case, that the the infiltrate is actually entering the anterior chamber in specific cases like that, would you think there would be a value addition with a systemic antibiotic, considering that we are dealing with a very severe infection? If so, which is your preference?
Screen, make it full screen, please. Slideshow, नीचे जाके. First slide पे आ जाइए. Please come on slide 1 and then screen show. Slide.
Yes.
May I make a comment about the antibiotics while we're waiting?
Please, please, Dr. Tu.
No, well, I'll wait.
No, please,
Back,
please
back.
go.
Yeah,
I think
just,
her screen is on. Yeah.
Yes. Just go back. Just go back, Indrajit. Just don't end the show. Just go back with the cursor. Just go back. You'll come to the first slide.
Yes.
Yeah, that's it. Okay, you can start now.
Okay. I'm Dr. Indrajit Kaur, Senior Resident, Dr. RP Center, AIMS, New Delhi. So I'm presenting a case of microbial keratitis that I have titled as Defeated by Medicine, Saved by the Scalpel. So it's a case of 24-year-old male patient who is a student from Haryana, presented to Dr. RP Center OPD with chief complaint of redness and watering in left eye for 20 days. So patient was apparently asymptomatic when there was history of insect fall in left eye, which was associated with diminution of vision, and the patient has complaint of redness and watering. There is no history of contact lens use, no systemic illness. So patient consultant outside ophthalmologist, and patient was diagnosed as microbial keratitis, and patient was started on antibacterial and antifungal medication. Initially moxifloxacin and netamycin was started, and later on shifted to concentrated antibacterials. Now coming to ocular examination, the visual acuity in right eye is 6/6, in left eye it is hand movement close to face, normal limit. So a left eye examination showing corneal ulcer, which has dry looking and have feathery margins, and there is hypopion of approximately 2.5 mm, and which was mobile, and there is infiltrate size, and epithelial defect was slightly bigger than the infiltrate size. So coming to further examination, intraocular pressure in right eye is 16 millimeter of mercury, and in left eye it is digitally normal, and there is poor glow in the left eye. So patient underwent ultrasound posterior segment, which was grossly anechoic, and there is no optic nerve head cupping. So anterior segment OCT was done, that show there is hyperreflectivity in interior 2/3 of corneal stroma, that showing suggestive of infiltrates in interior 2/3. On day of presentation, corneal scraping was done, that gram staining shows pus cell, and KOH mount shows fungal elements. So on the basis of corneal scraping report, we have made final diagnosis of microbial keratitis. Fungal etiology was made. So patient was started on gatifloxacin 0.5% 6 times a day as a bacterial cover, and netamycin 5% 1 hourly. And patient was already in advanced stage, and we have added voriconazole as adjunct to netamycin, and tablet voriconazole 200 mg PD was started. So on day two of admission, there is worsening, that showing there is increase in epithelial defect and hypopion, that may be suggestive of other etiological agent apart from fungal etiology. So on culture sensitivity, we got bacterial culture sensitivity show Acinetobacter, that was sensitive to polymyxin, ceftazidime, and ceftriaxone, but was resistant to gatifloxacin, and there is no growth on fungal culture sensitivity was noted. And on basis of culture sensitivity, final diagnosis of left eye mixed keratitis, bacterial plus fungal etiology was made. So on the basis of culture report, as patient was already on cephalosporin group from outside, so we have started polymyxin B 30,000 international unit 1 hourly along with other treatment. So this is the serial photographs of serial clinical picture. There is infiltrate was reducing in size and there is margins were well defined, but there is no further improvement in the clinical course. So we have planned for targeted therapy. The intracameral and intrastomal voriconazole injection was given on day 12 and day 15 of presentation. So this is post intrastomal intracameral injection clinical picture. So there is no significant improvement in the clinical course. So we have attempted PAC-CXL following Hafizi et al. Guidelines. These are clinical pictures of PAC-CXL 1 week after PAC-CXL. There is response, but that not up to not up to the complete cure of microbial keratitis. So further, we have made final plan of surgical intervention. The patient underwent therapeutic deep anterior lamellar keratoplasty using non-optical grade cornea. Intracameral and interface wash was given with injection voriconazole. So these are clinical pictures of post-operative day 1 that showing there is no residual infiltrate attached. So post-operatively, we have continued concentrated polymyxin B, 30,000 international unit, and natamycin and voriconazole started along with other cycloplastic and anti-glaucoma medications. So this is the final post-op picture of 5 weeks. That is showing there is no recurrence was noted on post-operative 5 week post-op, and also loose sutures were removed at this stage. Thank you.
So that was a really interesting case you presented, where you have shown everything ranging from drops to DAL, in one go. And, you started with antifungal treatment, and then there was a doubt of a contamination, and then you gave intrastromal, intracameral. Then you did the slightly non-traditional DALC for a fungal keratitis. So I invite Dr. Tushar to describe us a little more in detail about each step. But before that, I have some specific questions for you. You co-manage the case with her, I suppose?
Yes.
Yeah, so I have some specific questions for you. So when this kind of bacterial organism crops up in culture, when you have seen the smear to show fungus, what do you actually look for? Because sometimes I may think it's a secondary infection. I may rule out contamination of the drops that the patient is using. And I may like to rule out a contamination of the specimen also. So I'd probably look for, how many colonies and how many plates it's grown on and things like that. So how do you know whether this is incidental or causative to the infection?
Yeah, so I'll address this question and in the discussion in the description part only. So this case highlights the challenges we face, on a day-to-day basis, where we get, you saw the amount of drugs the patient had already was treated with. The entire pharmacy was used. And see, the smear made it very clear that the fungal element was there. The reason why we took the bacterial culture report into cognizance was that the patient was worsening in a way with the antifungal therapy along with the oral therapy. So the clinical I always the importance of it has to be made in conjunction with what I'm seeing on a day-to-day basis, on a daily basis. These patients are followed up daily basis. Admitted patients are followed up every 12 hours. So it all depends on how the patient is progressing or not progressing. So if the patient is progressing, I would not probably even look at the microbiology in many cases, because the patient is already progressing. Whatever we are doing is working. If the patient, however, is worsening, And then if there is something which comes up in microbiology, and again bolstering it with the clinical experience that a lot of our patients come with mixed etiology, we almost never ever see a pure fungal keratitis in RP center. Most of our fungal patients of fungal keratitis do have an additional element of bacterial keratitis. Now that is the fact that it may be gram positive or gram negative is a different matter. I mean, there is no sort of specific correlation which we have seen that, okay, fungal keratitis will come with gram positive or gram negative keratitis. But yes, we do see most of our cases are of a mixed etiology. The second thing, we also DLK in this is actually not exactly a DALK. This is more of a DLK because some bit of stromal tissue was also left. So the reason for that was that on OCT we could very clearly see a posterior layer of uninvolved cornea, and this patient was offered a therapeutic PK much earlier actually, and the patient that's why the PAC-CXL came into the picture. He was in fact offered we sort of planned therapeutic PK, and he had read up I think a lot on Google and everything, and he absolutely refused to undergo any surgery at that point. And then we came up with this idea that, okay, let us try PAC-CXL. Something had to be done differently. Now, when that also did not work, it did seem to work in the initial period. She showed the 1 week post-op. Actually, I asked her to reduce the slides. She had put a whole lot of intervening slides as well. So when the PAC-CXL also sort of stopped working, then we talked to the patient, and then we had a good brainstorming on this, and the OCT showed that there was a clear posterior stroma. So in this particular case, it's hardly ever our surgery of choice. Fortunately, it worked quite well in this case, and we could get away
I
with
think
it.
all is well that ends well. You really,
Yes.
it ended up beautifully. But I'm going to, for
Yes.
debate's sake, use that very point that you made. I totally agree with you that the ASOCD did show that the close to the decimates involvement was very less. Therefore, the
Yes.
DALK kind of paid off.
Yes.
But then if you flip back a little bit, this patient had, for all the intense infection, at least in the beginning, a crescent of very clear cornea. That bodes
Yes.
very well for intrastromal injections which you did, because
Yes.
we know that
Yes. Yes.
these injections should be given in the adjoining
Normal side.
normal cornea,
Yes.
normal
Normal
cornea.
cornea. Yes, to make
Yeah,
a
but by
barrage
the
there.
very
Yes.
same token that you had a clear strip of pre-decimates infection-free zone, did you had to combine it with an intracameral injection? I thought that was a little bit of an overkill doing both
So
together,
so
especially when the posterior stroma is
yes,
free.
yes. So the reason was twofold. The patient had already the insides of the eye had already been exposed to the intracameral antimicrobials before coming to us. So it was not a choice that we were the first ones to enter the anterior chamber. So that also affects the decision. If the patient hadn't had an intracameral before, yes, I would have sort of gone with this theory. The second was that if you see in the periphery carefully in the intervening pictures, the infection had in the peripheral region, the infection was starting to become full thickness. Even when we did the the DLK, we did I think it was that area from where the patient had undergone intracameral injections before. I think that tunnel or whatever that thing was had got infected as well. And we were also a little skeptical that, that area is being left. But our theory was that we are in a way debulking 95% and probably giving him a better chance. And since he was absolutely against, because when we explained to him
Another
that there is
form of
yes, when we
invasive
explained to him,
surgery.
yes, when we explained to him that there is this surgery we can do where, the insides of the eye, we will not go in and we will, do this unless it is absolutely required. So that is how we got convinced for getting a surgery done. I counseled him
So,
personally. Yes.
yeah,
Dr.
that seems
Agarwal,
to have
what
worked
was
very
the
well,
culture
actually.
growth
So,
from
anybody
the
else on the panel? Yes, ma'am. Anybody else on the panel who would agree with all of this or differ from this approach in the various steps that the patient has gone through?
Yeah, I think instead of agreeing or disagree, Dr. Agarwal, do you send that material, whatever removed from the lamellar keratoplasty, for again culture or histopathology, and what was the organism isolated there?
Yes, Dr. Indrajit.
What did the
I
button
think
show, Indrajit?
I think we did track. I'm forgetting at this moment. I will not remember, but I think because we had a discussion with with our ocular, the person who does the ocular pathology, because we were trying to track the pathology, because they are very well able to find the fungus on pathology, and we hardly, because in therapeutic PK mostly it's not needed because we have removed the entire button. In this particular case, we did try to track. I'm forgetting because I think we never needed the reports again. That's why it's not registered with me, because as I said in the previous case also, I go to microbiology only when my clinical sense is failing. So that's why I'm not able to sort of recall the reports right now. Otherwise, I would have 100% remembered. But I think
Anybody
Dr.
else?
I'll reconfirm with Dr. Indrajit.
Yeah, sure. You can tell us when you're ready.
Yes.
Dr. Jeremy, Dr. Tu, any thoughts on DALC for an infection like this with fungal keratitis and a secondary infection? And do you think that the ASOC really helped the decision making? And any thoughts on intrastromal versus intracameral? My vote would be intrastromal in this kind of case. Not a fan of intracameral, and here there was a present of clear cornea. But then any differences of opinion, Dr. Tu, Dr. Seedsman, Bhupesh? I'm not seeing any more people on my panel.
I would say that the AIOS OCT was helpful because I would have avoided the intracameral injections. I think the intrastromals are probably going to be more effective and give you a longer depot of effect. So not that I don't think there was anything wrong with intracamerals. I think they're fairly well tolerated, but I think in this case, more important would have been the intrastromal. But I think the case was managed beautifully, and even with the patient's resistance to corneal transplantation, I think it was to his advantage, because I think one of the things when you see one of these patients, you often rush into corneal transplantation, but without going through the process of trying to figure out what antimicrobials may be helpful to support you afterwards. I mean, if you do a therapeutic keratoplasty and don't have an idea of what medical therapy is going to be helpful to control any residual infection, the outcome is usually poor. And so in addition to the surgical part of it, I think the medical part is actually very important, just in case you're wrong. So meaning that if you don't get deep enough or you don't get lateral enough and you have residual infection, if you have a loculated infection in the back and you have no idea what antimicrobials you should be using to combat it, I think the results are going to be poor. So I think going through this entire process was very beneficial for the patient, in knowing what you can use after the transplantation is done. So
what do you think should be the endpoint of a manual dissection in a case like this? Is it when you're not seeing the infiltrate anymore, or would you want to see clear cornea? Would you go till the decimates? Or is it anybody's guess?
For me, it's the anterior chamber, because usually we do penetrating keratoplasty for most of these. We don't do DALC. I mean, we do DALC for other reasons, but for infections, we normally will go. Right. At least in my practice, we usually go full thickness. So that's probably a different answer than you're looking for.
We don't as well. For fungus, even I don't have experience doing DALC that very much.
I have done few cases, and
yes, ma'am.
I would go up to the decimates in these cases. One, because in fungal, it's very difficult to assess how deep it has gone. I think even with ASOCT, it may not be that easy, because the hyphae can penetrate and you may not be able to see. And that is the reason why therapeutic DALC I am little reserved for to do it for fungal keratitis. And these cases has to be followed very closely, because the reinfection can come in case of fungal infections. Of course, in acanthamoeba and bacterial infections, I have done T-DALC usually, and even microsporidiosis when it is still in the midstromal level or something. But in fungal, it's quite difficult, but sometimes we can escape, but we have to be very careful about these cases.
Correct. In his case, I think the absence of endoexudates clearly visible on the ASOCT was a clinching point that worked in his favor.
Hello, can I ask a question?
Yeah, please.
Yourself, please. And can you update on the culture reports and the histopath available, whatever they
Yes,
were
sir. The
post-op?
post-operatively, the host cornea was sent for histopathology and also microbiology report, and that shows aspergillus fungus.
Okay.
Right. So, Bhupesh, Christy, Dr. Jeremy, any other input on the
Yes.
DALC and on the injections?
So one very nicely managed case. But one thing is, which is sort of take home can be taken if you are doing this many interventions, like giving intrastromal voriconazole and subjecting the patient on antibiotics and 2 antifungals. I think repeated scraping, if patient is not responding or worsening, or doing Post-CXL, gives sometime a clue that whether we are dealing a really infective cause or the infection has been already resolved and we are dealing with a non-healing defect status post infected ulcer. Because I have some cases where actually infection resolved, but you're not getting any case, any culture or smear positivity on the ulcer, becomes like a sterile non-healing defect with a well-defined edges, and they respond to just stopping the medication or application of ocular surface procedure like AFG or fluoroscopy. So one other observation from this presentation was that repeated scraping, if you are having worsening in spite of all these medication, is a good idea. Any suggestions?
If I might, I know that you were asking about systemic. I know that this bacterial thing has wandered into fungus now, as Dr. Ravathi mentioned. But about systemic antibiotics for bacterial keratitis, the one thing I would suggest is that, I mean, I think for fungal infections, I think systemics can be very helpful. But I wouldn't discount the value of subconjunctival injection of antibacterial medications. You can get anterior chamber levels with that. And so if you're looking to get higher intracameral levels, I think a subconjunctival injection is probably preferable to systemic antibacterials. So, you know, the cephalosporins are very well tolerated subconjunctivally, less so the aminoglycosides, but they are as well. And so I think that getting back to your original question in the break, if you're thinking about trying to get intracameral levels, I think a subconjunctival injection is simple. It can be done in the clinic very easily. You don't need a microscope, and you'll get good levels in the anterior chamber.
So in the context, continuing with your answer, in the context of systemic antibacterial, would you reserve it for patients who have a perforation or who've had injury or surgery where we know that the reach is going to be higher, or even for virgin infections?
So one of the things that it depends on who's lecturing our residents, but all of a sudden, you know, in the GEC, we'll find that every single ulcer with a hypopyon is getting an ultrasound. And the studies are very clear. The consecutive endophthalmitis from a bacterial ulcer is very uncommon. So
exactly,
unless there's absolute proof that there's intracameral infection, I don't think that systemics or subconjunctival injections need to be done in those cases. So, and I would dissuade them from doing ultrasounds because often you find things that are partially actionable, and you know, they end up with a vitrectomy when they shouldn't. So. I think the literature is very clear that consecutive endophthalmitis is very, very uncommon.
Correct. Yeah, consecutive endophthalmitis is in a simple corneal ulcer is very, very rare. I agree with you. So before we move on to the next case with Dr. Revathi's moderation, is there anything that Dr. Radhika Tandon would like to add based on the vast experience of RP center cases that they see? Ma'am, any addition?
Yeah, Radhika, I'm going to be summarizing all the learnings together at the end.
Fine,
so
fine.
I will
We'll
reserve my points till then. Okay,
Sure.
Thank you.
We'll save on time and effort that way.
Yeah,
so,
yeah.
Back to you, Revathi ma'am, to take over the session as well as the case from your institute. We've saved the best for the last, I think.
Yeah, we'll go to the, no, it's not like that because it's a little different pathology she is going to present. That's why we kept it at the end. So Dr. Namita will present her case now. Invite Namita.
Good evening, all. Am I audible?
Yes, you can share your slides. Yes, we can see the
Is it
slides.
visible? Yes, ma'am. Good evening, all. Myself, Dr. Namita, Cornea Fellow from Aravind, Coimbatore. Today, I am presenting a case under the guidance of Dr. Revati, ma'am. I title my presentation as a bewildering situation. So, 18-year-old female presented to us with complaints of defective vision, photophobia in the left eye since 1 month. She was a regular contact lens user since wearers of contact lens user and a monthly disposable type of contact lens. History of presenting illness, she had a history of redness and watering 1 month ago in the left eye. There was no history of overnight use of contact lens, no history of any injury, no history of any exposure to contaminated water. She was previously treated at an outside hospital where she was subsequently diagnosed with contact lens induced keratitis in left eye, and the culture of the contact lens in solution grew Pseudomonas. So, according to the sensitivity, they started her with 5% amikacin and Vicomos eye drops hourly. Followed by, she was referred contact lens and was getting symptomatically better. 3 weeks later, she presented to our OPD with a recurrence of symptoms. On examination, her head posture, ocular posture was normal, facial symmetry was maintained. Uncorrected visual acuity in the right eye was 4/60, improving to 6/9, and left eye was 4/60, improving to 6/16. Slit lamp examination of the right eye was within normal limits. Left eye showed lid edema, conjunctival condition. Cornea showed multiple patchy anterior stromal scars with 2 active infiltrates in the mid-periphery with a mid-stromal ring-like lesion in the center. Rest of the findings was normal, sensation was present. So this was a clinical picture showing the patchy stromal scars with inferior active infiltrates and a mid-stromal ring-like lesion. So at this stage, we had a confusion what was the ring it is. So we had a thought like whether it is an acanthamoeba keratitis ring infiltrate or it could be something else. So when we look into the picture closely, we will be able to see a faint gray-white, well-demarcated ring lesion, which is present in the mid-stroma or in the deeper layer. And there was no evidence of stromal edema or any epithelial breakdown. There was no signs of any radial perineural keratitis. Sensation was also present, and symptoms also was a milder, and the onset was late after 1 to 2 weeks of presentation. So we thought of the presence of the immune-mediated Wesley's ring, which is a non-infectious ring and type 3 hypersensitivity reaction to foreign antigens. So we proceeded with the investigation to confirm the diagnosis. The microbiological workup was done. Corneal scraping was negative and culture lead no growth. Also, we performed confocal microscopy where there was no evidence of any cyst, only polymorphs was seen. So after the thorough investigation and the proper clinical examination, the diagnosis was pointing towards the immune-mediated Wesley's ring and a post-bacterial infection. So we started her with a topical antibiotic steroid medication and deferred contact lens use. The follow-up visit, vision was the same in the follow-up day 3, and the density of the ring started reducing and the infiltrate started healing. 1 week follow-up, her visual acuity has started improving. Best corrected visual acuity in the left eye was 6/18, and examination showed a patchy anterior stromal scars with a healing immune ring. So this was a 1 week follow-up picture and followed by 3 weeks clinical picture where we can see the ring where the density is reducing. Concluding that not all ring infiltrates in contact lens induced infections are infectious, but some may present as an immune response following bacterial infection. And both Pseudomonas and acanthamoeba keratitis may present as a ring infiltrate, and early detection and appropriate treatment helps in the control of infection and further complication. So few references. This is a article in American Journal of Ophthalmology in where they had a similar picture like our case, where a ring-shaped keratitis appeared in the left eye of a 37-year-old contact lens wearer after a day of 7. And the microbiological investigation of contact lens solution revealed Pseudomonas growth, but there was no clinical or laboratory evidence of any infection. They started her with 1% prednisolone acetate and the seen a resolution of the ring. The ring formation was due to the endotoxin-initiated property-mediated antibody-independent complement activation. This is another journal where a Wesley's ring phenomenon was described the anatomical and immunological basis underlying Wesley string formation. The central cornea has fewer immune cells and lower levels of components even compared to the peripheral cornea, so helping in preserving its transparency by reducing immune and inflammatory responses. And corticosteroids was the mainstay of treatment. This is a case of bilateral Wesley string in a contact lens wearer, where a 27-year-old contact lens wearer had a bilateral anterior stromal infiltrate with Wesley string. Contact lens solution grew Pseudomonas, and they treated with topical prednisolone along with oral valcyclovir, and a 6-week therapy was given. The ring resolved over the course of several months. Thank you.
Thank you, Namita. You can stop sharing your presentation. And we presented this case mainly to show that most of our cases are CL related, the bacterial keratitis. And this one is mainly we presented because as you see that culture from the contact lens and the solution and case, all these things usually help in identifying the organisms when we see a contact lens associated infection. But sometimes the clinical picture also we have to match. And though the Pseudomonas grew in the initial culture done outside, the clinical picture, as you have seen, it's not very conferring towards Pseudomonas infection or a very severe Pseudomonas infection in that matter. And then if you see and she responded initially for antibiotic therapy. And then after stopping the antibiotics, after 2 weeks, she again presented with this ring. That's why she was referred to us to rule out acanthamoeba. And actually, at this stage, I wanted to stop and ask questions to the panel, especially Dr. Seidsman and also Dr. Tu, who both were involved very much in acanthamoeba infections. At this stage, what would you would have thought? And Dr. Tu?
I think your thought process is great. With a ring infiltrate, you certainly can have infectious and inflammatory causes. And with infections, you always have inflammation. So it's very common to have a secondary inflammation. Also with many bugs, not just acanthamoeba, there are many Pseudomonas, strep pneumonia. The inflammatory ones can often have a ring. And so I think sort of our principle of any infectious keratitis is you always have to presume it's infectious. Even if you are culture negative, and especially I would have given a little, I think it was a Pseudomonas infection in the setting of contact lens, and it had a secondary inflammatory component. There are also surprising cases where we're culture negative from the case in the cornea, and in our lab we have, I work with a colleague who's able to do deep sequencing, and then that's where we find the Pseudomonas. So I think in the setting of a contact lens and a ring infiltrate, that should be infectious in our differential for the first 10 things. And then we can consider a secondary inflammatory component with it. And as Dr. Elmer mentioned before, each strain of bacteria has a different predisposition to generating a certain amount of inflammation, as do host factors. So I think that thought process is correct: infectious, 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 and then add a steroid. But not every ring is acanthamoeba, to your point.
Revati ma'am, when the patient presented with the inflammatory ring in the subsequent visit, was there a breakdown of epithelium on top? Because the epithelium was intact at that stage, judging by the intactness of the epithelium, the grayish appearance of the infiltrate, and relatively quiet eye, I think we can piece together that this is probably inflammatory. As an afterthought, in the person in the clinic always gets puzzled. But in my mind, an infective etiology, unless it comes endogenously or by a deep implantation of a foreign body, these are two exceptions, but otherwise you always have an overlying epithelial defect. So that may be a pointer. Am I right or wrong?
Yeah, there was no epithelial defect, no epithelial irregularity. And even that's why this ring appeared definitely different. That's why we suspected immune ring in the beginning itself. But to be on the safer side, 1 or 2 superficial infiltration we scraped and nothing grew from it. Probably she was sterilized, even the infection was sterilized even before because of the treatment given before. So at this stage, it's mainly inflammatory. That's what our take. And this is one stage where we have to go for steroid in case of bacterial infection. And another thing, this Wesley's ring will take a longer time to clear. Usually any inflammation with steroid, it will clear off very fast. Even hypopion, all these things. But these rings, somehow, they will take a longer time. This is my experience even in the previous few cases also. I don't know why. Maybe others like Baga or Dr. Christie or Dr. Elmer can share their experience.
So I see one or two of these a year referred in for acanthamoeba, just like this patient was. And when I first saw this many years ago, I actually did everything. I biopsied it, and everything came back negative. And so I think one of the characteristics that you see with these are that they're often off center. They're not, usually when you think of acanthamoeba, the central ring, it's usually larger and denser. And so when you see it off center, it can often be paracentral. There's usually that dot in the center, which is usually where probably the infection was, and then you have the immune ring around it. But in almost no cases have I ever seen this be acanthamoeba. These are all inflammatory in nature, and I think there's probably a nest of antigen in the center in that little dot where the original infection was that causes the immune ring to occur. And it seems to occur in younger individuals, I think, as well, where their immune systems are more robust. But yeah, these are seldom anything to be concerned about from an infection standpoint. I mean, they're all immune, but whether there's actually an infection underlying it. So I think I agree with the treatment and the clinical acumen, looking at that and realizing that it didn't really look like an acanthamoeba. And if you can do non-invasive testing, if you have confocal microscopy available and it doesn't show anything, I think it is unlikely that any additional investigation is necessary. I think steroids are fine for these patients.
Thank you. Christy, would you like to add something?
Nothing, ma'am. So it was very well managed. I think all the points were already told. Thank you for sharing.
Dr. Baga?
Yeah, can you hear me?
Yeah, yes.
Yeah, so I think all the points are covered. But in addition to the ring infiltrate, if you're seeing mid-stromal haze or the fine pigmentation on the endothelium and symptoms, and along with early stages, if you see the periphery, the presence of RK and radial keratoneuritis, that actually is a very important sign to clinical sign to make this for acanthamoeba. So that addition which I look for in addition to confocal. But yes, I have seen this type of rare rings, and that take time to respond, as you very rightly mentioned, and they take respond. And those cases, many times, if you culture the contact lens or the case solution or the solution, they grew pseudomonas. So we sometimes think that this are the toxin related, and they respond to corticosteroids as in your case.
Thank you, Dr. Baga. That's what even in this case also I was looking for the perineuritis mainly. Though the patient was relatively comfortable for acanthamoeba, but I was looking carefully for the perineuritis part, because if it is there, definitely I would have suspected only acanthamoeba. And fortunately we have confocal, and that also did not show any sign of fungus or even cyst. That's why, like, with the confidence, we were going ahead with contact lens, this corticosteroids. Dr. Tandon, would you like to add something?
Yes, so I would like to, do I summarize now with everything that we've learned, or do you want anything specific for this case further? No. Okay, so I'm just going to...
Yeah, you
yeah.
can start summarizing, Dr.
Yes.
Yes.
I'm just going to apologize that I'm going to keep my video off because I'm traveling in the car and it's a bit dark. So it might be easier for you to just listen to my voice. Now, firstly, I'd say that we've really learned a lot in this last 45 minutes. We've learned that bacterial keratitis can present in different ways. And given the experience from different institutions, tertiary care all over the country with a different spectrum of cases. A lot of the principles that we were aware of have been highlighted. At the same time, the rare scenarios that one may deal with have also come to the front because all of us are highly experienced and we see patients routinely which have been treated in different places and not been not resolved, and they come to us at the very end stage. So the learning from today's webinar, I hope, is going to be helpful to other institutions who may not have this much of experience to understand what are the basic principles. So let's start with certain common things that have come to the front. If you see across the board, a lot of young people have unfortunately come with infectious keratitis. And so this is a cause for concern. And some of them have come after procedure. So we had a PRK mentioned, bilateral PRK, and there were 2 patients who had bilateral PRK done, which is, I mean, usual, but post-PRK. What was not clear from that case history was whether they were done in the same center and on the same day, and we can have some more insight into that later on. But PRK is a procedure which is always a matter of concern, and it requires a lot of counseling before, and very, very careful post-op care has to be communicated to the patient. And as was clearly mentioned, even the OT protocols, etc., have to be very, very strict. The thing, again, which wasn't very clear in the PRK presentation is what was their pre-operative prep regime. So there are some clinics who just have a very walk-in approach. That patient is flown in from some country and then they have a very quick workup and then they just operated the next day. I know that that happens in some places and I would really discourage that practice. So if you're going for a PRK, there's going to be removal of the epithelium and you need to prep the patient properly before. We usually give pre-op antibiotics for 3 days that we can discuss maybe with the other panelists. So the bilateral PRK in that two patients with bilateral infection, that is something which is, I hope that the message goes out that this is a very strong possibility and one has to preempt and prevent it. The cases were, of course, very well managed, and so that highlighted the proper treatment of them, and also the further risk, which is compounded by the fact that the nerves are damaged. So the neurotrophic state, how they can progress very fast, and so on. The other thing which has come, another theme which has come through in all the presentations is how much of multi-drug resistant organisms we are seeing, Pseudomonas. So as Dr. Jeremy nicely said, whenever you see a multi-drug resistant organism, a Pseudomonas, one usually thinks of nosocomial, hospital-based, and we usually see that a lot with hospital-based donor cornea retrieval when they retrieve from the mortuary. So getting so much of multi-drug resistant organisms from the community is of course for concern. And usually soil contamination and water contamination, we associate more with acanthamoeba and fungi. So I'm very, very concerned about this multi-drug resistant Pseudomonas, which is coming from the community. Though Dr. Jeremy did say that it can come from water, maybe that's maybe poor hygiene in the toilets, maybe the taps and things like that. But even then, why is it multi-drug resistant? So multi-drug resistant gram-negative organism, to the extent that it's resistant to everything, that's something that maybe we've already come across 5-6 cases just in this group of presentations. We can just compare notes and see what could be the reason and source for that. Regarding the point about gentamicin and which are the go-to antibiotics, as Tushar very nicely said, we do need to keep having the microbiology surveillance and have periodic analysis of what your reports are showing. So the microbiologist can, tell you the trends that nowadays, there's a high rate of resistance to so antibiotic. Right in the beginning, we were very hopeful that the 4th-generation fluoroquinolones would be free of resistance, but within a year or two of their use, we found that you do have resistance to both moxifloxacin and gatifloxacin. So in North India, presently, Pseudomonas that we get, which is resistant to everything, is almost 100% sensitive to polymyxin B. Of late, there have been a few cases resistant to polymyxin B as well. So the moment we have Pseudomonas which is resistant to everything, or if you even have a clinical presentation, we have a strong suspicion of Pseudomonas and already been on multiple antibiotics before, usually we would start polymyxin B as our empirical antibiotic given that background. Talking about gentamicin, that is another possibility, though in the north we still have gentamicin resistance. And if gentamicin drops are not available, at least in North India, the injection is readily available. So one could prepare drops from the injection if necessary. But we don't usually fall on gentamicin as our go-to antibiotic if there is Pseudomonas, which is resistant to the whole range of antibiotics. Now, the patient who had required talc. So though we did say that, when the ASOCT was done, the infection was not that deep, that patient had already had 2 intracameral washes. And though the infection was not that deep, the patient did have the hypopion. Now, the question is whether the hypopion was partially treated because of the previous intrastromals or whether that was related to the Acinetobacter. That's a little difficult to say, but if you remember that within 24 hours of starting the gatifloxacin, the patient's epithelial defect and the superficial infection had worsened. So my impression is that patient did truly have a mixed infection. It may have started as a fungal to begin with, and maybe there was, secondary invasion with the gram-negative organism, and it did turn out to be resistant to gatifloxacin, and that can explain how it would just continue to worsen, and then the polymyxin B helped, and then of course we consideration the patient's thoughts, and it's always good to engage the patient in the thought process and the decision making process rather than dictating to the patient always that this is what is required for you. So as it happened, the outcome was good in that patient with the therapeutic talc, and I feel that it's not a necessary thing that every fungal infection one should I feel it was a good illustration of a fungal infection, which perhaps had been partially contained by all the procedures, the intrastromal injections, and then the cross-linking. So then the talc was a good option at that time, and luckily it worked. Another point which came through very nicely is how topical steroids were used judiciously for control of inflammation in Pseudomonas ulcers. But here, a very, very strong word of caution. We have very experienced people where they admitted the patients or kept the patient on very close follow-up. And the use of the topical steroids was about 4, maximum 6 times a day because you just wanted to control the inflammation. And you're going to start it when you're sure the infection is coming under control. So typically about 4 or 5 days after starting the antibiotic, when you're very, very confident that the infection is coming under control, and now you just have to help the eye get rid of the inflammation, also to tone down the inflammation so that there is an improvement in and you can salvage the rest of the cornea. So there is some people may get the wrong message and use steroids 1 to 2 hourly. That is not to be done because that becomes a kind of an immunosuppressive dose. You would only use 1 to 2 hourly steroids if it was a graft in rejection. That's a different topic altogether. So if going to use topical steroids, I would say that it ideally should be judiciously with a very, very trained eye, or very, very, you keep the patient under very close follow-up and tell the patient, I'm starting this drop. It could go either way. It's extremely important that we review you in 24 to 48 hours. And if you feel any worsening in any way, come back sooner. But the message was very, very nice and very good to show how associated use of topical steroids can really help to salvage. And one thing I would say that Pseudomonas looks very devastating, and one used to always think that that's the end of the eye, but it can respond very well, and sometimes the patient can continue to improve. And sometimes very severe ulcers may even end up with a pretty transparent cornea after a year or two down the line. So tell the patient not to panic, because if a young person gets this opacity, they sometimes go the other extreme and get very depressed about it. The whole family gets very panicky. So it's always good to tell them that, don't worry, it'll take some time, and with the healing, the eye, your vision will keep improving. With that, I would say that it's been a wonderful session, and I hope that the community of ophthalmologists has benefited. I'm going to try to light on in the car so you can see me a
Yes,
little
ma'am.
bit. Yeah.
Visible.
Yes.
Excellent, Radhika. Thank you very much. And that shows the experience, and you summarized everything very clearly. And the take home points are also very clear. Thank you. And others in the panel, and Dr. Radhika Natarajan, my co-moderator, would you like to add anything?
No, I think it's been a lovely set of cases chosen by you, Revati ma'am, from one end of the spectrum to the other. So we've had cases where, we've had bacterial infection post some sort of surgery. Then we've had one which was dealt with a little different type of surgery. And then, the last case was the, different one in which the inflammation masqueraded as infection. So I think we've had one end of the spectrum to the other, and difficult cases managed very well by everybody. I learned a lot. So, I think everybody else on the panel would have had the same experience.
Yeah. Dr. Elmer, Dr. Seitzman.
Thanks for including me. It's really always a fun discussion to hear how cases are managed across the globe.
Thank you.
Thank you very much for including me. It's always an educational experience. I'm hoping MDR doesn't come to the United States. But thank you for your expertise and your pioneering of its treatment for us.
Yeah, thank you both of you for joining so early in the morning. Thank you very much. AIOS is very thankful to you. And thank you all the presenters who presented beautiful cases. As Radhika pointed out, a really variety of cases, and it's really a treat to listen to the discussion as well as the presentations, and all the panel. They nicely discussed all the cases. Thank you very much, all of you. I think it's time for us to wind up. Thank you all.
Thank you.
Thank
Good
you,
evening.
Thank you. Good night, everybody. And good morning to Elma and Jeremy. I hope you have a good weekend.
Thank you. You too.
Yeah.